Hello, and welcome to Chapter 20, Hemolytic Anemia, Non-Immune Defects. So in Table 20-1, we have all the causes of hemolytic anemias from non-immune antagonists. Within the first category, we will discuss microangiopathic hemolytic anemia. There are three conditions in this category. They include hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and disseminated intravascular coagulation. All three of these conditions, the antagonist is caused by thrombi within the microcirculation, and there's physical damage to the erythrocytes going through the microthrombi. Now, the other conditions have caused hemolysis within the venules as well, and we will be going over them as an overview. Okay, let's discuss microangiopathic hemolytic anemia. It is a hemolytic process caused by microcirculatory lesions, which leads to damage of the endothelial lining of these small vessels. Deposition of platelets and fibrin within the microvasculature cause thrombus formation within these blood vessels. When red cells are forced through these, they fragment, causing schistocytes, Okay, so within the MAHA category, let's first discuss hemolytic uremic syndrome, which is a multi-system disorder characterized by a clinical triad of features. Number one being red cell fragmentation or schistocytes. Two, seeing thrombocytopenia. And three, renal insufficiency or acute nephropathy. There are two groups of hemolytic uremic syndrome categorized as either having diarrhea associated. 90% of these cases are in children under 5, either from the Shiga toxin-producing E. coli. Now, the second group would be a non-diarrhea associated type of HUS, which is an atypical and more likely to occur. This is usually associated with other types of conditions such as lupus, cancer, diabetes, or sometimes other streptococcus pneumonial infections observed in children and adults. So let's discuss the pathophysiology of HUS caused by E. coli 0517 H7 or S. dysentery type 1. This intestinal infection causes damage to the intestinal mucosa. The toxin is absorbed into the circulation and it damages the endothelial glomerulus within the microvasculature. This cytotoxic damage from the endothelial lining releases prothrombotic vasoactive platelet aggregating substances which form platelet fibrin thrombi within this circulature. The highest incidence of HUS are children 0 to 1 years old. There is a very acute onset where you have anemia right away, sudden pallor, you have abdominal pain, vomiting, and fever, and of course bloody diarrhea and macroscopic hematuria. So the most serious complication can lead to acute renal failure and eventually lead to chronic renal insufficiency. CNS symptoms can be present and patients can experience minor seizures. Now, lab findings associated with HUS are a moderate to severe normocytic normochromic anemia is a classification where hemoglobin can range from 7 to 9 grams per deciliter. Here we see many schistocytes, helmet cells, spherocytes, and Burr cells, Polychromasia with those cells, some nucleated red cells occasionally. You might see a leukocytosis, and the platelet count here can be low or markedly decreased, as seen in this image here. You will have hemoglobinemia and increased bilirubin due to the breakdown of the cells, and you'll have some renal insufficiency too, seen by increased BUN, creatinine, or sometimes metabolic acidosis. You might see protein in the urine, as well as pyuria or cells. You might have protein casts in your urine as well. Coagulation results, your PT and PTT are usually normal. So this will help you determine between HUS and another type of microangiopathic hemolytic anemia. Well, let's talk about the therapy for HUS. So first, the Shigella toxin like E. coli should have, most of the cases here recover, about 80% recover on their own, but you have to do some general supportive care. The mortality from this is very low, 5 to 15% that are diagnosed early and have supportive care do very, very well. So you're talking about giving them IV hydration. You have no problems with coagulation or any drugs are needed. Now, in certain cases, plasma exchange is not indicative, but it is with atypical HUS caused by secondary types of conditions, and in those you may or may not need a kidney transplant. There are certain drugs as well that are recombinant monoclonal that are effective with the atypical HUS, and normally monoclonal antibodies against Shiga toxin to prevent immunity may be exceptional in cases with E. coli toxin. So let's talk about thrombotic, thrombocytopenic purpura as the next condition within the MAHA umbrella. This is an acute disorder with platelet aggregation on the microvascular endothelium. It usually affects young adults between 20 and 50 years old, and more females than males. It's possibly due to a precipitating factor of pregnancy in 10 to 25% of the cases, and infection in about 40% of the cases. Now, this presents with neurological symptoms, and it can also have renal dysfunction, along with the microangiopathic hemolytic anemia and thrombocytopenia. So the platelet microthrombi form in the microcirculation that are responsible for most of the symptoms seen in the condition that result in organ ischemia. The endothelia of the kidneys, brains, heart, pancreas, and spleen are the most particularly vulnerable to TTP. Now, to better understand TTP, let's first think about what happens when there's vessel injury. So let's talk about von Willebrand factor and the proteolytic enzyme ADAM-TS13. So when the endothelium is injured, the platelets play an essential role in orchestrating the blood clotting process needed to seal the damaged vessel. So the recruitment and activation of platelets at the site of damage is dependent on von Willebrand factor. So the endothelial cells located near the site of damage produce von Willebrand factor and secrete it, enticing platelets to come and adhere and plug up the hole. The platelets also initiate the clotting cascades, which forms this insoluble fibrin clot. Now, normally what happens is once this is sealed, the body needs a way to break down this clot. But in TTP, the plasma-derived proteolytic enzyme normally used to break down this clot, ADAM TS13, is either deficient or there is some kind of mutation to this enzyme, leading this large mass in the microcirculature. So if platelets or red cells go through, they start to fragment and cause schistocytes. Clinically, HUS and TTP do present often familiar, so there is some characteristics that are associated with differentiating between the two. So let's discuss the most common things that are seen in both of these conditions. So first, in TTP, they usually involve young adults aged 20 to 50 years old, where in HUS, we usually see this in children less than 5 years old. So a couple commonalities: yes, you have hemolytic anemia with red cell fragmentation in both of these conditions, as well as thrombocytopenia. Okay? We also do see some renal dysfunction in TTP, but with TTP, we're also seeing other organ systems being involved too, such as the brain, pancreas, and heart. Now with HUS, this is an acute renal failure condition that we see. And although there are CNS symptoms in both HUS and TTP, TTP has more severe CNS symptoms. And you're going to see, a lot of the times, fever associated with TTP. The lab findings with TTP, the hemoglobin drops to about 8 or 9 grams per deciliter. You're seeing a normocytic, normochromic type of anemia. The MCV can be variable depending on the number of schistocytes. If you have a very large amount of schistocytes, your MCV may drop. In the meantime, your bone marrow will try to produce a lot more cells, so you might have some polychromasia, nucleated red cells, you might have a leukocytosis, and your coagulation tests are usually normal. Okay, you have an increased bilirubin, hemoglobinemia, severe thrombocytopenia. So this is a very common thing that you have to be paying attention to, where in this image here you see one platelet in this picture. Now, as for therapy for TTP, plasma exchange with fresh frozen plasma usually provides the ADAM TS13 protease and removes any autoantibody if that was a cause in acquired types of TTP. You can also provide cryosupernatant, which it lacks the large von Willebrand factor multimers, but it does contain the von Willebrand factor cleaving protease. Certain drugs have been used as well as antiplatelet agents and steroids. Okay, so the last group under the MAHA umbrella is disseminated intravascular coagulation. This is a complex thrombohemorrhagic condition that normally disrupts the coagulation process. The causes are bacterial sepsis, neoplasms, serious types of trauma, immunological disorders, and miscellaneous due to snake or insect venom or particular drugs. Here, there's damage to the endothelial lining of vessels, which release prothromboplastic substances that activate the coagulation mechanism, which also activates platelets and aggregates them into a deposition of fibrin. So the formation of microthrombi in the microvasculature causes red cells to fragment to form schistocytes. Now the complications are very dire. There's thrombotic occlusion of vessels, bleeding, and organ failure that can happen very quickly. Now, this is a very serious consumptive coagulopathy. Okay, here's a peripheral blood picture of someone with DIC. You have severe thrombocytopenia. Where are those platelets? Okay. Notice all the schistocytes as well. This is leading to very serious bleeding complications, especially if you have your coagulation factors consumed. Now let's talk about the coagulation results with DIC. So this is a consumptive coagulopathy. So with microvascular damage, you see the platelet count going to the area and out of circulation. So the platelet count and fibrinogen, which helps close that clot and make a fibrin clot stable, will be decreased as it's consumed by the actual process. Now, here we've talked a little bit, remember the blue top PT and PTT coagulation factors? Now these involve all of the coagulation factors that help form that fibrin clot. They will prolong because the test cannot clot. So these two tests are measuring the time a clot is made depending on the cascade of the test. So they are going to be increased or prolonged, okay? Which also includes the breakdown of any of those factors, such as a D-dimer. We've already discussed the peripheral smear and many schistocytes and helmet cells. And again, the platelet count will be visualized as decreased or severely decreased. So therapy for DIC include red blood cells, platelet transfusions, or fresh frozen plasma, or specific factor concentrates to replace anything that was lost or consumed with this quick process. Again, we have to treat the underlying cause to stop this disorder from happening and provide supportive therapy. Now, HELLP syndrome, I have seen in the hospital this syndrome, which is an obstetric complication, be associated and lead to DIC. But again, it falls under the hemolytic anemias. So here, the HELLP syndrome is an obstetric complication that has hemolysis, elevated liver enzymes, and low platelet syndrome. It usually develops in the third trimester of pregnancy and is usually associated with preeclampsia or eclampsia, meaning high blood pressure. Now the causes, it causes capillary endothelial damage and intravascular platelet activation, which in turn causes microthrombi within the microvasculature. Due to hypertension, you can also see with this proteinuria and thrombocytopenia. The lab findings, you will see schistocytes. Your platelets are going to be under 100 times 10 to the 9 per liter. With hemolysis and thrombocytopenia, it's less severe than TTP or HUS. You're also seeing an increase in liver enzymes, which will lead you to this certain type of condition. Your bilirubin will be elevated, and your coagulation tests are usually normal. Now, the therapy is corticosteroid therapy or cortisone administration. Let's finish up with other causes of non-immune related hemolytic anemia. So let's talk first about malignant hypertension. So this is an extremely high blood pressure that develops rapidly and causes some types of organ damage. So normally, a normal person's blood pressure is 120/80. So a person with malignant hypertension has a blood pressure that's typically above 180/20. So with this, we have endothelial damage or injury, fibrinoid necrosis of the arterioles, and deposition of fibrin, which causes lyased red cells. and activation of platelets. So you're going to see red cell fragmentation in your peripheral smear, low platelets, and an increased lactate dehydrogenase. It has been shown that certain types of prosthetic heart valves can cause hemolytic anemia, but it's a very uncommon complication, especially with the new designs of heart valves. But sometimes as platelet or red cells go through the microcirculature with these appliances, they could shear off where you could see excessive schistocytes due to the turbulence of blood flow around the valve, which causes a shear stress of the fragmentation, and sometimes your platelet count can go down a little bit. As for thermal injury, hemolytic anemia occurs within the first 24 to 48 hours after extensive burns to the body. Now again, the degree of hemolysis depends on the percentage of the body area burned, and heat causes the denaturation of spectrin inside the red cell membrane. So within the peripheral smear, you're going to see red cell budding, you'll see schistocytes, spherocytes, and hemoglobinuria and hemoglobinemia after 48 hours. Another type of hemolytic anemia is caused by exercise-induced hemoglobinuria or March hemoglobinuria with strenuous exercise. You have transient intravascular hemolysis, and usually there's no anemia. So the traumatic disruption of red blood cells are caused from the pressure on the soles during running or walking for long periods of time. You don't really have schistocytes here, but you could see hemoglobinuria and hemoglobinemia. And we'll wrap up by concluding the hemolytic anemia is caused by antagonists in the blood. So first, we have a peripheral smear here from a patient with malaria. So malarial parasites are inside of the red blood cell, which causes a mild normocytic normochromic type of anemia. It can be severe and may cause thrombocytopenia, especially if the parasitemia level is very high. So this causes extravascular destruction of the parasitized cell. It's usually diagnosed by finding the life cycle stage within the red blood cell on the peripheral smear. As for this clinical picture, you have an infectious agent or a protozoan, usually from a rodent or cattle, and it's called babesiosis. So you have several infected red cells in the field with an arrow that have the internal protozoa. It's usually transmitted to humans through ticks, and they look like an intracellular ring-like structure. And here again we have extravascular hemolysis and a mild to moderate anemia with increased reticulocytes, decreased platelets, increased liver enzymes, and bilirubin. Okay, animal venoms such as bees, wasps, spiders, scorpions, most commonly the brown recluse spider, due to local lesions. Systemic symptoms occur within 15% of individuals, causing hemolysis or damage to the red cell membrane. They can also fix or activate complement to lyse the red blood cells as well. Last but not least, chemicals and drugs. Many are dose-dependent that cause red cell hemolysis. You're also going to see hemoglobinuria and hemoglobinemia with these kinds of conditions. You might see cyanosis, and very severely bone marrow aplasia can occur.